The parathyroid hormone is a principal regulator of plasma calcium concentrations, and it is produced by the parathyroid glands. These are four rice-sized glands on the posterior surface of the thyroid gland. The parathyroid hormone is released in response to decrease in plasma calcium ion concentration, or hypocalcemia. The parathyroid hormone is essential for life as it produces a fast-acting response to hypocalcemia. It does this by promoting transfer of calcium ions from the bone fluid into plasma, and this is particularly life-saving. However, in chronic hypocalcemia, the parathyroid hormone stimulates dissolution of bone. To fully understand how this happens, we need to appreciate the structure of bone tissue at a cellular level. At the core of major bones in the body lies blood vessels surrounded by clusters of mineralized bone. In between the mineralized bone is bone fluid that contains soluble calcium. As mentioned before, this soluble calcium provides a life-saving calcium source for quick release of calcium into plasma during hypocalcemia. Now, the rest of the bone tissue is interspersed with three main types of cells: osteoblasts, osteoclasts, and osteocytes. Osteoblasts and osteoclasts play a significant role in calcium metabolism, where osteoclasts dissolve mineralized bone and osteoblasts crystallize calcium from its soluble form into mineralized bone. So now back to our story. In chronic hypocalcemia, the parathyroid hormone stimulates dissolution of bone. It does so by stimulating osteoclasts. However, osteoclasts do not have receptors for the parathyroid hormone, but osteoblasts do. And so the stimulation of osteoclasts by the parathyroid hormone is an indirect one, where the parathyroid hormone binds to receptors on osteoblasts, and they in turn secrete a protein called RANKL, for which osteoclasts have a receptor. RANKL therefore binds to osteoclasts and stimulates them to gobble up crystallized bone and release calcium and phosphate ions. The parathyroid hormone also stimulates the cells of the distal convoluted tubule of the kidney to eliminate phosphate ions and reabsorb calcium ions during urine formation. The excretion of phosphate ions in urine is really important as it distorts the ratio of calcium and phosphate ions in the blood and prevents recrystallization of these two ions in the blood. If this didn't happen, you will end up with crystallized bone forming perhaps within your blood vessels, which is not an ideal situation. Now, the parathyroid hormone targets an enzyme in the kidney called 1-alpha hydroxylase, which converts calcidiol to active calcitriol. Now, calcidiol is the pre-hormone or is the inactive version of vitamin D, and calcitriol is the active form of vitamin D. Now, calcitriol stimulates the GI tract to absorb calcium and phosphate. It also stimulates the proximal convoluted tubule in the kidneys to reabsorb calcium ions from urine. Okay, so I know that we've touched on how the parathyroid hormone acts on increasing the amount of active vitamin D produced by the kidney, but I just want us to focus a little bit more on vitamin D as a hormone. So let's be clear, vitamin D is not really a vitamin, but a hormone. It is initially synthesized from cholesterol in skin keratinocytes exposed to ultraviolet radiation from the sun. Ultraviolet radiation converts cholesterol to vitamin D3, and vitamin D3 is carried in the bloodstream to the liver, where it is converted into a prohormone known as calcidiol, or inactive vitamin D. Calcidiol undergoes chemical modification in the kidney to then become active calcitriol. This chemical modification is catalyzed by an enzyme known as 1-alpha hydroxylase. However, the parathyroid hormone increases the production of this particular enzyme, which then leads to the increased conversion of calcidiol to calcitriol. And so that is vitamin D essentially, and the role and how it is involved in calcium metabolism. As I mentioned earlier, the principal site of action for calcitriol is the GI tract, where it increases absorption of calcium from the GI tract into plasma. Okay, so let's quickly recap the parathyroid hormone. So it is produced by the parathyroid glands, which are 4 right-sized glands located on the posterior region of the thyroid gland. And this hormone is produced in response to hypocalcemia. Now, what it does, it promotes transfer of calcium ions from bone fluid into plasma. It indirectly promotes osteoclastic activity to release calcium and phosphate ions. At the same time, it stimulates cells of the distal convoluted tubule to remove phosphate ions from the body through urine, and it promotes the reuptake of calcium ions by the proximal convoluted tubule. Also, it promotes production of 1-alpha. It promotes the production of 1-alpha hydroxylase in kidneys. 1-alpha hydroxylase catalyzes the conversion of calcidiol to calcitriol, and calcitriol in turn stimulates increased calcium absorption from the GI tract into plasma. Now, all these together force plasma calcium levels back up to normal physiological levels. So far, we have discussed how hypocalcemia is dealt with by the body. Now let's try and understand how the body deals with hypercalcemia, that is high levels of plasma calcium concentration. When plasma calcium concentration is elevated beyond their physiological range, clear cells, also known as C cells, also known as parafollicular cells, located within the thyroid gland recognize this change and secrete the hormone known as calcitonin into the blood. Now, calcitonin is a 32 amino acid peptide which is stored in secretory vesicles in parafollicular cells. The way calcitonin restores physiological calcium levels is by binding to calcitonin receptors on osteoclasts. The binding of calcitonin to receptors on osteoclasts inhibits osteoclastic bone resorption or osteoclastic activity, so the destruction of or the dissolution of crystallized bone. This in turn brings plasma calcium concentration back to the physiological acceptable range. Now that I've told you the role of calcitonin in calcium homeostasis, let me tell you why calcitonin may not be as important as I may have convinced you it is. Patients whose thyroid glands, together with their parafollicular cells, have been surgically removed are still able to keep their plasma calcium concentration within the normal physiological range, despite the absence of calcitonin producing parafollicular cells. Furthermore, patients with rare tumors of their parafollicular cells, where their parafollicular cells are producing tons and tons of calcitonin, almost 50 to 100 fold more calcitonin than normal, are still able to maintain normal physiological plasma calcium concentrations. And so you're probably thinking that the past 5 minutes have been a waste of time, since I've essentially explained in detail how calcitonin works, but then told you it's actually not that important. Trust me, your time is not wasted for two main reasons. Patients with hypercalcemia are administered miacalcin, which is salmon calcitonin extract. This is 10 times more potent than human calcitonin, and it is prescribed for osteoporosis. Now, the mode of action of this drug is exactly as I've explained for calcitonin. Secondly, 50 years after calcitonin was discovered, its functions are still being investigated. New research suggests that calcitonin may have a role in pregnancy and lactation. Alright, let's recap. The normal physiological range of plasma calcium concentration is 2.2 to 2.6 millimole per liter. During hypocalcemia, the parathyroid gland secretes parathyroid hormone. The parathyroid hormone causes quick uptake of calcium from bone fluid into the blood or into plasma and bone resorption. The parathyroid hormone also causes the excretion of phosphate ions through urine and retention of calcium ions in blood. In the kidney, the parathyroid hormone stimulates the production of 1-alpha hydroxylase, which in turn converts calcidiol to calcitriol. Calcitriol stimulates calcium uptake from the GI tract into plasma. During hypercalcemia, parafollicular cells of the thyroid gland sense the high plasma concentration and release their secretory vesicles containing calcitonin. Calcitonin inhibits osteoclastic activity by directly binding to receptors on osteoclasts. The reduced osteoclastic activity in turn reduces plasma calcium levels. Okay, so disorders in calcium metabolism usually arise from either too much or too little parathyroid hormone or a deficiency in vitamin D. Now, the parathyroid hormone is essential to life. In its absence, death occurs rapidly due to respiratory stress, often caused by defective neuromuscular junction activity. Let's look at hypocalcemia and what causes it. So hypocalcemia is caused mostly by hypoparathyroidism, chronic kidney disease, or hyperventilation. And the symptoms you often get when you're suffering from hypocalcemia is tetany, which is muscle spasms, paraesthesia, which is essentially a feeling of tingling or prickling sensation, and cardiac arrhythmias or depression. And it makes sense because you have less calcium, you don't have enough calcium for your muscles, for your heart muscles to use, and so you end up with cardiac conditions. Okay, so let's look at hypercalcemia. So causes of hypercalcemia are essentially hyperparathyroidism and cancers of the bone, such as myeloma. Now, the symptoms of hypercalcemia can be summarized as stones, bones, and abdominal groans. Or I think the long version of that is stones, bones, groans, moans, thrones, and psychiatric overtones. Now, you can look them up online, but the stones refers to kidney stones formed from calcium. The bones refers to bone-related complications such as osteitis, fibrosa cystica, and osteoporosis. Groans refers to gastrointestinal symptoms of constipation, indigestion, nausea, peptic ulcers, and acute pancreatitis. And moans, refers to just the feeling of malaise and lethargy. Thrones refers to constipation, and essentially, since you're sitting on a porcelain toilet, you're sitting on a throne, hence thrones. And psychiatric overtones, referring to the effect on the central nervous system, where the person is left feeling confused, depressed, and sometimes having memory loss and sometimes psychosis as well. And so that's it. Those are the fundamentals of calcium metabolism. Thank you for listening, and please let me know what you thought about this session.